Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me, as always, is CMOS MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. Mike Hahn. Mike is the Chief Medical Information Officer for CareConnect, an independent business unit of MultiCare Health Systems, charged with providing innovative information technology services to both internal and external constituents. He is board certified by the American Board of Urology and Urological Surgery and the American Board of Preventative Medicine and Clinical Informatics. Prior to his tenure at MultiCare, Mike was the Chief of Surgery and CMIO at Pacific Medical Centers, Associate Medical Director of the Uniformed Services Family Health Plan, and a System Surgical Informaticist for Providence. Mike attended Brown University, where he earned a bachelor's degree in biochemistry. He received his MD from the University of Michigan and completed his urology training at the George Washington University School of Medicine. He earned a certificate in medical management from the University of Washington and is currently enrolled in the executive MBA program at the Wharton School of Business. He lives in Bellevue with his wife, 2 children in high school, and 2 dogs. When he's not thinking about governing, maintaining, and optimizing the electronic health record, he enjoys tennis, downhill skiing, and wine tasting. Mike, welcome to the show.
Thank you. Wow, that's a great intro.
So Mike, I'm actually going to go off script. My first question. So that's okay. So in your bio, it sounds like a lot of your time is spent thinking about governing, maintaining, and optimizing the EHR. I just want to check in. How much time are you spending a week on that? Because it sounds like that might not leave enough time for tennis, skiing, and wine tasting.
So it takes up quite a bit of time. I got to be honest. MultiCare's instance of Epic has been around quite a while. You know, the ambulatory part of our instance is I believe over 20 years old, and so there's a lot of code that's sort of hidden in the nooks and crannies of our instance of Epic, and so there's never a shortage of surprises when we're trying to change something or build something. I think that healthcare is a calling. There's a lot of other things that we can do that make more money, take less time, cause less heartache. But the bottom line is that if you're going to be involved in healthcare, you really need to be bought into the vision and mission of improving health. And so when I first started this job at MultiCare, I wanted to take about a month off between my previous gig and this one. And Ben actually convinced me that they needed me and that I should come in at least part-time. And so we finagled something where I was working part-time. And what I found was that I started working part-time, and there were all these sort of problems and issues that were coming up. And when I was cycling, or when I was in the shower, or when I was, swimming laps or what have you, I found myself sort of thinking through these things. And one of my buddies got, he said, Mike, they got you for shower time. They got you for your shower time, right? Because you're sitting there in the shower and you're trying to think through these problems and issues. And even though you're part-time, you're still working through things as if you're full-time. Mm-hmm. So, I do tend to dwell on things, and I do tend to think through things. And there's a significant amount of bleed over from my professional life into my personal life and hobbies, for better or for worse. Mm. But I do think that part of that comes from healthcare being a calling, and that it's not something that you can just sort of turn on and turn off. So I guess that's really where I would. That's really where I go with that is that even when I'm and it's probably my terrible work-life balance, but yeah, I mean, on the chairlift, are there times where I'm thinking through, when I was taking care of patients? Were there times where I would think through is there times where I would think through informatics problems on the chairlift or, in between points? Yeah, absolutely. And so, wine tasting in general is a very social activity. And typically I taste with other physicians, but also other software. Here in the Seattle area, there are plenty of software engineers, and just being able to bounce ideas off of people from different backgrounds does tend to creep into those conversations 100%. And some of my biggest insights have been in those types of situations. And so yeah, I do think that my hobbies they do tend towards these situations that give me a place where I can still discuss work but have fun at the same time.
You know what's
and that's
funny?
Probably why, and it's probably why I wrote it that way.
I love that. So it's funny you mentioned and we joke about the value of let's say the shower time, but I know for me, some of my best ideas about seamless have come just trying to clear my head, while taking a shower, or like on my daily 45-minute walk outside, or just that mental time alone. Some of my best ideas have come through that. So actually, I think in many ways, there should be a premium on what seeps into your shower time or your cycling time, whatever it is, or your skiing time, because that's actually a lot of times when your best thinking comes through. So, I think organizations need to realize that's actually really valuable time that if work's seeping into that, that's meaningful. So
and again, one of my old bosses used to say, I don't pay you 40 hours a week, right? I pay you for your expertise, and I pay you for your thought leadership. And unfortunately, that doesn't end at the end of your 8-hour day or your 10-hour day. You still, if you really enjoy what you do, you still it ends up bleeding over into that time, for better or for worse. And so it's I think that these types of jobs, that's the beauty of these types of jobs, is that you get to think through problems and issues, and again, it never really leaves you.
And Mike, you have this amazing story of how you got to this point. You mentioned that medicine is very much a calling, and so I'm wondering if you could take us back to medical school and your roller coaster into residency and beyond. Just because I think a lot of folks who are way early in their training probably have a lot of the same thoughts that you had going through training, but often when we're facing struggles in medical school and residency, we don't talk about it a lot. So do you mind kind of taking us back to medical school and kind of what your experience was going into residency?
Yeah, no, I mean, I think I certainly think it's an interesting narrative, but it's about myself, right? And so I'm a third generation physician. So both, so my grandfather was a physician. Both my parents were physicians. I was accepted to medical school right out of high school. I was accepted into an 8-year program right out of high school, and so I never considered it as much of a privilege as I should have, and I think that a lot of that had to do with my maturity level at that point. I didn't appreciate the experience or the journey while I was there, and I hate to say this, but I probably considered it more of a birthright than a privilege. And for those of us that have gone through medical school, if that's the attitude that you go into it with, it can be a pretty painful experience. It's not. It's something that you have to be mentally and emotionally and physically prepared for, because it is the 4 years of medical school are an assault on your mind. So, after going through 3 years of medical school and starting my clinical rotations, I was really unsure as to whether or not I wanted to finish. I think that I was fairly certain that I would finish medical school, but did I want to go on with training, and did I want to go on to a career in practicing medicine? And so during my 4th year, I had a chance to rotate on urology, at the University of Michigan. And I think that looking back, I really liked the people that I was on service with. I liked the residents, I liked the attendings, and I felt like, wow, I could really be one of these people. And I actually enjoyed the work as well. It was the first rotation in anywhere in medical school where I was like, wow, this is something that I could really do. And so urology here in the States is what's called an early match specialty. And so it was already September of my fourth year, and we needed to have our applications in probably a month or two after that. But they supported me. They got me through it. I did my applications, and then in December during my fourth year of medical school, my dogs are going to start barking right now.
You have a lot of dogs in the audience.
Yeah.
Podcast,
so see, I was able to predict the future. All right, so my wife just closed the door. And so in December of my fourth year, I got notice that I did not match. And I did not match, and it was the first time in my life up until that point that I didn't get what I had gone for. I didn't achieve what I thought that I would achieve, and to me that was sort of a sign from God. Okay, now I know I'm not going to become a doctor. I'm going to graduate from medical school.
But did you apply for anything else, or was it you only applied urology?
Yeah. Okay. Urology, and at the time there was probably 215 spots or so in the entire country, and they had 400 medical students that applied for it. So starting December of my fourth year of medical school, I started to apply. As a backup, I applied to the School of Public Health at the University of Michigan to get an MPH after medical school. I applied for jobs in investment banking and management consulting. Wow. And it was an interesting time in that I got responses of, gosh, we really wish that you had a little bit more clinical experience, or gosh, it would be nice if you had more IT experience, because we need more IT expertise than anything else. And so push came to shove, I graduated from medical school in June, and on July 5th, I got a phone call from the Department of Urology at George Washington University saying, so one of our guys has decided that he doesn't want the position anymore. And typically residency start on July 1st. And so he came in, and for one reason or another, he decided that he didn't want it anymore. They had a spot to fill emergently, and they basically looked to see who on their match list hadn't matched. And apparently my name came up pretty early. Wow. And they reached out, and a couple of weeks later, I was starting my internship at George Washington, which was a real roller coaster, but it was a great experience. Urology residency was pretty amazing. I really enjoyed my time at George Washington, Fairfax Hospital, Washington, D.C. I look back on those years very fondly, although, during the time, it was difficult, I'm not going to lie. But I think that having a new mindset, going into residency, where like this wasn't my birthright, but this is something that I really needed to appreciate, and all the opportunities that were afforded me. I think it changed my perspective, and it allowed me to do well, and keep the patient at the center, and really understand why it is that I was there.
And sorry, Mike, can I ask you, like, if you didn't get that call from George Washington, were you planning to try and apply to residency again that year, or at that point were you just like, you know what, like mentally, like, you moved on maybe, or?
I had moved on.
Wow.
I had moved on. It was I was done.
So was that did you have to think a long time about saying yes to that opportunity, or how hard was that decision to say, you know what, I guess I'm going to do urology?
I I still remember, actually. I call my mom, right? I call my mom, and she was at her office, and I said, so, I got, and I was working for the CFO of the medical center at Michigan, uh, and I wasn't particularly sure what he was going to do with me, but I was there, and I said, hey mom, I got this phone call from the University of, from George Washington, saying that they need someone to fill a urology spot. And she said, so when are you leaving?
Yeah.
And I said, well, I haven't decided whether or not I'm going to go. And she's like, what do you mean you haven't decided? And I took a weekend to chew on it, and really in the end, it 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 um it wasn't a difficult decision
Mhm.
for me to make. I was able to sort of I was able to make that decision pretty quickly.
That's amazing. I love that story.
Yeah. I love it in particular, like just that shift in mindset. It's almost like that needed to happen to then go on with this whole career. And like you said, put the patients at the center, not think so much about yourself, but really understand why you're doing what you're doing. I love that, Mike. And then actually, you became a urologist, you went on with that. And then about a decade ago, you began your journey into health IT. So you knew, back then how important IT was and how they were looking for that. But you got really involved with digital health. You got really into Epic. You became a super user for the Department of Surgery, and then an Epic physician champion where you led a team of super users, basically the liaison between your IT and the provider staff. What motivated you to first get involved with tech?
Huh. I I think that I wish that I could say that it was super intentional, right? I mean, I wish that I could say, oh yeah, this experience, during my fourth year of medical school, where I was told, if you really want this job, you need to have more IT experience. Um, I had, I had grown up, using computers and learning how to code in high school. I never really took it anywhere, but I certainly, the introduction to coding in high school allowed me to have an understanding of a lot of the logic, and how things were supposed to work. Once we stood up Epic, I got pretty good at it very quickly, and I think that it was more a function of my understanding of the underlying logic that was being used to create to create what Epic really was, and so I got good at it pretty quickly, and I was part of the physician leadership, and quite honestly, it was that position, the CMO, who was our de facto informatics leader before there was really an informatics program, had left. And I was part of physician leadership, and they said we really need somebody to help out with this. And it was, oh, Mike, you're good at Epic, and you're already a physician leader. Can you step into this role? And so, like a lot of us, from that generation of informaticists, uh, I sort of call us accidental informaticists, or because you sort of, I'm sure that there were more thoughtful people than me that actually took on the role, intentionally. But for me, if you had asked me in 2005, when I was finishing my urology residency, whether or not I'd be involved in informatics, I would have said, "What's informatics?" Number one, and then number two, I would have said, no, I'm going to be operating my brains out, and literally, 6 or 7 years after residency was completed, I was leading a small informatics team, and so it's not as intentional as one might think. It was more based upon interest, and again, being in the right place in the right time. So we're gonna talk about. I mean, we can talk about Malcolm Gladwell, and we can talk about outliers, and yeah. I mean, I think that really I had some of the skills that were necessary, and I was in the right place in the right time, and this opportunity was offered to me, and I took it. I wish it was more intentional. Gosh, I wish it was more intentional, but it was I felt like it was a great opportunity.
Mm-hmm. It was funny. I remember I saw this great presentation by a gentleman named Jordan Banks. Jordan Banks used to be the head of Facebook Canada, and he was doing this convocation presentation for kind of his the university he graduated from, and he kind of put this little chart on the screen about showing how his career journey going from, I think he started off as a lawyer or something and ended up as the head of Facebook Canada. But he was telling the graduating class, if someone had asked me, 20 years ago where I was going to end up in my career, all the things I did along the way, I would have not predicted at all. And the only reason I ended up here at the time in his current role was just, saying yes to accidental opportunities that came along the way. And his whole point was, humans are just very bad at predicting the future, especially around career journeys. And the key thing is just like being open-minded, following your curiosity, not trying to plan everything out. And I think your story is a great one of that. I mean, I think a big thing that you did was that you said yes and you followed your curiosity. And yeah, I mean, clearly it was, informatics wasn't even a word that you used back then, but I just feel like a lot of really successful people have just like let the accident opportunity not just show up, but actually say yes to it and put in the time and effort. And probably most people, even if they want to make it seem like the narrative was like pre-written by them, and probably in most cases it wasn't. I mean, can't imagine too many cases where people actually had planned out their entire careers and they were right. That just seems unreal to me. Maybe there's a few outliers there who exist, but
yeah, no, yeah, I think that I think that you're probably right. And if it were all planned out, it would be a little bit boring, wouldn't it? I mean, the twists and turns are sort of what make this an interesting journey.
Hey, can I ask you a random question? So, depending on where you worked in clinical informatics, you may have used Epic or Cerner or Meditech or something else. Do you feel like, talking to your colleagues and your experience as well, if you started off working with a certain EHR and you wanted to build a career in clinical informatics, is it easy to move? Let's say you wanted to move to a new health system and take on a leadership role with a totally different EHR. Does it really matter if you started off on a certain EHR but not another, or are the principles so common that if you were good, it doesn't really matter where you started?
I think the principles are common enough, and I mean, MultiCare's CHIO Ori Lotan, he actually started in a Cerner shop, and then he came over to MultiCare, which is an Epic shop. And so I think that the principles remain the same. I mean, your principles of clinical decision support, on the underlying logic, right? I mean, database architecture. I mean, we can talk about all these things, but I mean, I do think that if you're a good informaticist in Cerner, you can be a good informaticist in Epic. And one of my colleagues and friends, he's an informaticist for Providence, super talented guy, and Kang Su, and he started with Meditech, and now he's one of the best I know in terms of informatics, and he works for Prov and he works in Epic. And so I mean, I have so much respect for people who have been in different records and have led different records, because I think that can only make you better.
Totally. Mike, you were a member of Epic's urology steering board, and this was a national committee to improve the urology user experience. What would you say is the hardest thing about improving the clinician user experience when it comes to health IT?
So from a urology steering board perspective, it was neat to be on calls with you know urological informaticists. There's not a lot of us. We're out there, but there's not a lot of us.
Like you can count it on one hand, or
there's more than one hand, right? But I mean,
just two hands, maybe.
but maybe two hands. Uh, so I think that the most interesting thing was realizing how different, and this flies in the face of just what I just talked about in terms of why does what works here not work here. But what was really interesting was how far ahead certain places were in terms of of uh, of optimizing um, um, their instance of Epic from a urological perspective, and how far behind other instances were, and even when the steering board was able to align and say this is what we need, and Epic actually built it, how it wasn't as easy as you would think for these individual institutions to actually take on that upgrade, right? Because every institution had to do the value equation and basically say, okay, how much value is this going to bring to our institution? How much work build effort do I need to put into this? Do I build this for the 3 urologists that we have on staff when there are 60 primary care docs who are needing this, and this, right? And so I think it was eye-opening to try to see how difficult it was to get that sort of implemented across instances. And I saw it from Epic's perspective, right? I saw it from the vendor's perspective. It's like, ooh, wow, this is hard work. This is not easy to necessarily do, right? And it was, and as the customer, you always felt like, well, if they would just build it, then everyone could take it, or if they would just tell us what to do, then everyone could take it, and it wasn't true, right? And so I felt like that was the most interesting part of that experience, is the difficulties to sort out the differences between instances, even though they were still on the same electronic health record, and they were using the same vendor.
And Mike, is one of the challenges that people like yourself, who often end up on these kind of boards and advisory committees, you're typically the most visionary, forward-thinking, super users, and in some ways, sometimes you may not represent, let's call it, the average user. So even though everyone on that board would say, oh, absolutely, we would use this tomorrow, in the reality, the rest of your team would say, no, I don't really care to change what I'm doing.
Yeah. So, I mean, I think that certainly, building for for a super user or a power user to use Epic Speak, or building for your most comfortable end users, doesn't necessarily address those users that are sort of slower on the adoption curve, and are just struggling to keep up. And and it's something that that I think that we all struggle with in IT is, and something that I'm really thoughtful about lately is, we tend to add things to workflow. We don't do as good of a job as subtracting things from workflow. And so for that end user that you talk about that's not necessarily as savvy, we need to simplify the process. But in general, we really only add, and I would really like us to get to a place where we say, okay, these are the things that we really removed from what you need to do. How can we automate certain parts of the workflow to make your life easier? How can we make it so that you don't need to have a human do a lot of things that I think all of us understand that computers can do, right? And we just still we still haven't gotten there. And this is going to be me on my soapbox, but I mean, one of the things that bothers me the most about a lot of the AI and the machine learning that's going on out there, and this is my perception, it's like Watson comes in and says, hey, we're going to replace radiologists, and I think that's the wrong approach, in my humble opinion, because what you're trying to do is you're trying to replace the most complex part of healthcare, is the physician or the nurse, right? The healer. You're trying to replace that with AI and machine learning, when what we should be doing is that we should be going after the other parts of the process that are more painful. The prior authorization, the scheduling and registration, and I know that there are vendors out there that are doing this, but again, I mean, but really the big hoopla was around, we're gonna replace radiologists and pathologists. There was an editorial in JAMA that said that in 10 years there's going to be no radiology residency or something along those lines, and it hasn't come to fruition, thank God, right? But we really need to be looking at parts of the process that don't add as much value. And one way that I sort of think about it, I grew up in Detroit, and Henry Ford was this giant. There's he didn't, and I know that he had a fraught relationship with some of his workers, but again, I mean, he didn't try and replace the worker. He tried to make the job easier for the worker to do. And really we need to focus on making the easier parts of the job that we don't, the parts of the job that can be automated, as opposed to trying to replace the physician and at the same time adding more work for the physician or the nurse to do. So I'm all for simplification and automation, and but if we're going to replace doctors, let's make that at the very end, when we actually can do, when we removed all the non-value added things. And if that's 20 years from now or 50 years from now or 100 years from now, whatever, right? But I mean, there's so many parts of the process that we can focus on to make things easier.
I love that idea of, how do we eliminate complexity? How do we remove workflows and steps that aren't useful, or even maybe, arguably remove things we've implemented that actually aren't value add or useful? And so it's funny because I think a lot of times there's like probably pressure to build a resume of, oh, I did this new thing, I implemented this new thing, it was successful. But actually someone who came and said, hey, I got rid of these 10 things that weren't value add, and I saved everyone time and money because I deleted all these things in the workflow or the EHR or whatever it is, that should be celebrated. And I'm sure a lot of people would be like, hurrah, I don't have to go to that stupid meeting anymore or whatever, but we don't, it's almost like we don't celebrate removing complexity or non-value added things in them, or even things that used to be useful just aren't anymore over time. And it wasn't a bad idea at the beginning, but maybe it is now. But it's hard to, I think it's hard to celebrate, or it's not in the culture all the time to celebrate removing things, deleting things, even though, to your point, probably should be. Actually, people would be really happy.
And I mean, I'll give you an example, and it's hard. I'll give you an example that we're struggling with right now. Was a couple of years back, there was a change in the documentation rules for physician notes, where in the past we would have to document a certain number of review of systems, organ systems that were reviewed in the review systems, or we had to document a certain number of organ systems that we included in our physical exam, in order to be able to code a certain level of complexity for a visit. A couple of years ago, those rules were thrown out, and they were replaced with, we're going to base this completely either on time or on the complexity of your medical decision making, and you're no longer going to have to check the box in terms of I did 7 different organ systems in my physical examination, or I did 9 different organ systems in my review systems. And we thought that this would be a huge advance for physicians in terms of decreasing our documentation time, in terms of decreasing note bloat, in terms of reducing the number of characters that we would be using in our notes, in terms of reducing dictation time. And Chris Kelly, our ACMIO for data analytics here at MultiCare, did this. He did this study, and he looked at whether or not the length of physician notes, admittedly a crude metric, but still a metric. Was there any difference, before that law changing and after that regulation changing? And there's no difference. There's no difference, even though we've said, hey, you don't need to document that 11 organ system physical examination. You don't need to do that anymore. We can't break them of the habit.
Mm-hmm.
We cannot break them of that habit. And so that was, and there were a lot of us who felt like that was going to be a big win for a lot of physicians. And it ended up not being as much of a win as we thought it was going to be. And I don't know, and I'm not smart enough, or I don't know at this point, how do you force that issue, right? How do you say to the doc, hey, look, you're spending 20 minutes per note. I have a way to cut you down from 20 to 16. How can we get there? But I think that we can do better. I think that our end users deserve better. But I'm not 100% certain how we'll get there. But I do think that a net subtraction can sometimes, it's certainly not as sexy as that bright shiny new object, right? But I think that we can get to a point where subtraction is as sexy as that bright shiny new object.
There should be someone should get a presentation at Epic's UGM where all they do is talk about the 10 things that I got rid of last year. You got to make it sexy. You got to like get on stage. You got to celebrate it. Because I think unless we get recognized for it, people may not believe that the organization actually cares about it. Or, but yeah, that's a tough one. It's a tough one.
Definitely true. Well, Mike, I do want to talk a little bit about CareConnect. You're now the CMIO over there. Basically, CareConnect, as I understand it, it's a way to extend MultiCare's Epic instance to help serve the community, the broader community. Can you tell us a little bit more about the work that you're doing with CareConnect and why this effort is important?
Yeah, so the first instance that I was involved in was a very small instance. I mean, it was it was probably one of the smallest instances in the country where we only had 150 providers. It was an ambulatory only instance, and it was hard. It was hard work. It was hard work. It was hard to stay current, keep up with the upgrades and the updates that constantly kept on hitting us, as well as the optimizations that we just discussed. And I wasn't part of the initial discussions, but had Community Connect, which is what Epic calls it, been available at that time, I think I would have had a hard time saying no to a Community Connect relationship. And so, I had firsthand experience of what it was like to try and go Epic direct as a smaller institution. And I think that Epic's, market penetration in terms of smaller institutions speaks for itself. And they are trying to address some of that with I think Garden Plot is what it's called, but as well as the Community Connect program. The ability to extend an instance of Epic at a lower cost to organizations like my old one, it was meaningful to me, right? I mean, it was like, wow, that is pretty cool that MultiCare would go out and extend its instance to to certainly surrounding providers, but also other hospitals. Um, the thought of extending it to critical access hospitals, federally qualified health centers, tribal health clinics, all places that would, not necessarily be able to access, an industry leader vendor in terms of electronic health record, was meaningful to me, and it's certainly something that is uh, um, uh, it, I think that it was definitely meaningful to be able to offer it to people that, or clinics and patients who wouldn't otherwise be able to afford it.
Right.
So I think that I think that the CareConnect at MultiCare is I think that CareConnect, I don't want to use the word meaningful again, but I mean it's certainly mission and vision driven, and it appealed to me. I think that the other part of CareConnect that is so important, and I think that I touched on this before, was that MultiCare does not have a monopoly on everything that's right, and if we can get better together, I think that's the most important. I think that that's one of the other very important parts of having a program like CareConnect is that the ability to serve external customers, or getting to a point where you're good enough to serve external customers, will only improve your ability to serve internal stakeholders.
Yeah, makes a lot of sense. I love that idea. It's a very collaborative mindset of, let's grow and get better together and better serve maybe community and folks who can't have access to that necessarily. So that is really honorable, Mike, just being mindful of your time, we're going to jump to the fast 5 lightning round. This is basically 5 questions to get to know you better for our audience. First question that we have is, what is your favorite book or book you've gifted the most?
So in the last year, my favorite book was Think Again by Adam Grant. I actually gifted it to my entire team. So it checks both of the boxes there.
Awesome. Yeah. Question 2, who is a person, dead or alive, who you'd love to meet?
I struggle with this. There's so many people that I would love to meet. I think that in the end, it would have to come down to Jesus Christ. I mean, whether or not you're religious or not religious, or part of like the whole Judeo-Christian, world, I have so many questions.
Yeah, I agree with that one. Question 3, this one's different. Would you rather have super strength, super speed, or the ability to read people's minds?
So I thought about this one. I think, at first glance, it was the ability to read other people's minds, but then that could get a little bit scary. And so I think that for me, time is my most precious commodity. So I think I would take the speed over reading other people's minds.
Yeah, I love it.
Follow-up question. Do you think there's any downside to super speed? Because I think I totally agree. Like, reading people's minds, there can be a lot of downsides to that. But super speed, any real downsides to that power?
I think that the biggest downside would be not taking the time to smell the roses. Right? If you do everything fast, right, and like, let's say you go for a run, right, and you do your run really, really quickly, but you don't take in the view. Yesterday we went on a walk here with our dogs, and it was absolutely gorgeous. And if you just sort of ran through that and didn't, sort of take the time to take a look around and see how gorgeous it was, I think you'd probably be missing something.
I feel like also you almost would feel like you didn't earn something. So like imagine you had super speed and yeah, you run faster than like Usain Bolt or whatever, but then I wouldn't feel like I earned it. You know, I feel like, yeah, of course I'm the fastest person alive. Like I have super speed.
Well,
You're just like you're just lapping Usain Bolt.
Yeah.
I know, right? I mean, just be like, yeah, you know. I mean,
Yeah, that's fair. All right, question 4. What is something in healthcare you believe that others might find insane?
I think I think it's got to be the red tape. I think that I don't know if it's the same in Canada. I would imagine it's better, but I think that the amount of time, treasure, and effort that is spent on red tape here in the United States is, I don't think that anybody has any clue.
Yeah, definitely. Question 5. This one, Josh, we might have to get rid of this question eventually because it's now we're basically post-COVID now. But lockdown-related question: what is one hobby or activity you got into since the beginning of the pandemic?
I gotta tell you that my hobbies were always pretty COVID safe. I mean, tennis, skiing. You know, so I actually skied more days in 2020 than I had in years.
Wow.
And so the wine tasting took a little bit of a hit because it's such a social event. But I tried playing pickleball a couple of times.
Okay.
But other than that, really no new hobbies. It's been it's been sort of staying the course.
I like that you were outside for these hobbies, right? So you know, everybody else was forced inside. You're able to still get out there.
Oh yeah, skiing. I mean, skiing is definitely. I mean, I don't think skiing is definitely a COVID safe sport. And as is and tennis is pretty COVID safe too.
Yeah.
And indoor skiing is not that much fun. It's
yeah, indoor skiing
doesn't work very well.
No, it doesn't. Although there are places that have like these weird things that you can practice. Yeah, they're very weird.
That's amazing. Well, I gotta say, I tried pickleball as well. I actually quite like pickleball, coming from a tennis background, so that, you know, I thought it was pretty easy to pick up. And did you stick with it, or you played it?
I've only, you know, I played it at some dinner parties, but I haven't really stuck with it. It's fun. I mean, I'm sure that maybe I'll play it more when I get older.
Yeah, exactly. No, that's great. Well, Mike, again, thanks so much for taking the time to be on the show today. That's a wrap for this episode of the Digital Patient hosted by SeamlessMD. Follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Mike, again, thanks so much for taking the time.
Thank you, Mike.
It's my pleasure. Thank you very much.